Is there any questions before we start? For any topic? I think so far you have 5 topics. So we have these developments of malocclusions, development of occlusions, etiology of malocclusion, and then class 1, class 2, class 3. Any questions? No? No questions? No questions?
Doctor,
Yeah.
which is the most important topic?
Ayo, this is not questions lah. You're asking me what exam question will come on. No, I don't think I can tell you. I think they're all topics are equally important. There's no most important questions or topic. So I think for all the questions, all the topic have been taught, there's so-called the basic of the orthodontic. So I think you have to study all the topic. Any other questions? No?
I think there's no questions.
No questions. No questions, then they were done today. Oh, nice.
Okay, happy holidays.
Nah, I think we'll go through some tutorial together, okay?
All right.
Can you see my screen?
Yes.
Okay, all right. Okay. So I think the first topic is by Dr. Parker. Is the development of malocclusion, active malocclusion. So this one, you have to learn all the eruption date, then how the occlusion develop. So you have to go through the eruption sequence, timing, then you have to know what happened before eruption, after eruption, and how the occlusion established. Okay, so you have to know what's the features of this decidus and dentition, and then after that mixed dentition and permanent dentition. So this one just a compact. Then you have to know what's natal, neonatal teeth. Then this compact will appear when baby born. Then slowly, then we come to primary dentition. Then you have to remember the sequence eruption is A, B, D, C, E, not A, B, C, D, E. So always A, B, then D will come out first. Remember, the D will come out first before the C. For the primary dentition, it's upper and lower is the same. A, B, D, C, E. A, B, D, C, E. Remember, not A, B, C, D, E. Okay, then I'm going to 3 years old. 3 years old, you have all the decidus. Then these decidus, you have a lot of spaces between it. They call it physiological space. Then you have this primal space, which is mesial and distal to the upper and lower canine decidus. So you can know what's the name of these spaces. Physiological, or this one, primal space. Then after that, you have to know this flush terminal, then mesial terminal, and then the distal terminal, which will lead to class 1, class 2, class 3 molar relationship. So the flush terminal, then when the molar move forward, they become class 1. Can you see my cursor? Can you see my mouse?
Yeah, we can.
Okay, all right. Then the distal step, then when this one move forward, they become class 2. The mesial step, when the molar move forward, they become a class 3. So mesial step will lead to class 3 molar. Flush terminal will lead to class 1. Distal step will lead to class 2 molar relationship. Very important. This one I have to remember. Deep bite will settle down when the occlusion established. So the baby always end up with the deep bite at the beginning, then slowly the bite will open up. Okay, primary dentition, deep bite. Okay, so mixed dentition started. We have first adult teeth erupt, which is a 6 or sometimes the central incisor. Then we have the first transitional period, intertransitional period, and second transitional period. So the most important, I think, should be the first and the second. Intertransitional period, it means nothing will happen. Everything stable, looks same, before the 3, 4, 5 come out. So the first transition period is central incisor and sixes. This one you look at the incisor crowding. Then the second transition period, they look at the posterior crowding, 3, 4, 5. So when the 3, 4, 5 come out, only you know what we call the true pictures or the real picture of this crowding. So this one just summarize what I said just now. Easier, brush, distal. So this one will lead to class 3, class 1, class 2 malocclusion. Okay, this I just summarize what I say just now. Okay, summarize, okay. All right, so you see the baby incisor, they're usually upright. So when the permanent incisor come out, they're porcine slightly. So the incisor, permanent adult incisor, they always come out from the palatal. Then slowly they move forward. So they come out, then move forward. That's why the upper incisor porcine. Okay. Intertransitional, nothing happened. This one usually everything looks the same until 3, 4, 5 erupted. 3, 4, 5. 3, 4, 5 will stay till they erupted. Then it becomes second transitional period. So second transition period, you have to look at this leeway space. Leeway space, it means the space different between, the size different between 3, 4, 5 and decitus CDE. So CDE will be bigger than this 3, 4, 5. That's why I have space. So this leeway space used to mesialize molar. That's why the molar from the flush terminal, they move forward and become a class 1. That's how the baby or the kids usually look a bit class 2 molar from the beginning. Then slowly become class 1. Ugly ducting space is usually due to this physiological space. I mean, before the canine come out, then you have a lot of space at the frontier. The frontier always space. Then they call it median diastema or ugly ducting space. And this space usually will close when the canine come out. So when the canine come out, they will squeeze everything in the middle. That's why the space will close. So this picture just summarizes everything. So at the beginning, you see this lateral incisor that will be different angle, and they will displace distally. The root will be mesial. Then when the canine come out, then they'll squeeze the crown or the head into the middle. Then everything become upright, straight, and space are closed. Okay. Extension. Okay, then we come to permanent dentition. So remember the sequence again. Very important. Remember the sequence. So I think most common one for the maxilla is 6, 1, 2. 6, 1, 2. 2, 4, 5. Okay. I think the first one will be more common. 6, 1, 2, 4, 3, 5, 6, 5, 7. So the 3 usually will come after the 4. That's why you see the maxilla most commonly crowded 2 would be number 3. Number 3. Most common one would be number 3, the upper. So whoever come late or the last one to come, there are no seat for them. So the top one usually the canine will come last. That's why the canine become crooked. Then the mandible, the last one to come out is the second premolar, number 5. Number 5 become the last one to come out. That's why the lateral incisor become crowded or crooked, sometimes impacted. Remember the sequence and the timing also. Okay, this one curve for monsoon, curve for Wilson, curve for speed. Okay. Overjet, overbite, you have to understand what is overjet, overbite. That was normal range. Overlap, angulations, occlusion, molar relationship. Okay. condition. Okay. So first one, developments of the malocclusions, right? Development of the occlusions. Any questions? Quite simple. This topic is just to tell you from baby or prenatal, then until they become adult, how this teeth come out, what's the sequence, what's the timing, and how the extra bridge will come to contact with each other. Then sometimes if this something disturb the procedure or something happen in between, then they cause what we call a malocclusion. So for the upper, mostly canine will be crowded. Lower, second premolar will be crowded. Because there's some other malocclusion, the jaw will become crooked, then the jaw will become longer, then become class 2 and class 3 malocclusion. Okay, any question for this developments of the occlusion? If not, then we move to the next one. So the next one would be the cause of the malocclusion, etiology of the malocclusion. Okay. So etiology of malocclusion then divided into general factor and local factor. So general factor means general. Everything is so wide, the topic is so big. So it can be genetic, environment. Then local factor, it means everything is zoomed in, smaller. It means usually the number, the size, the position of the tooth. Then sometimes we have premature loss or the decidus refuse to go, so we call it prolonged retention. Then abnormal eruptions, it means the tooth in the wrong position. Ankylosis means the fusion between the teeth and the bone. Then the caries, improper dental restoration, all will affect the malocclusion. So then general factor, you can come to genetic, environmental, and sometimes can be due to trauma or accident, whether they are baby stage or adult stage or teenager stage. So general factor, okay. So this one is general factor. Dentition is local factor. Okay. Skeletal, class 1, class 2, class 3. Soft tissue, it can be the lips and the frenum. Mandible, this one is a congenital defect, cavity and palate. So hormone imbalance can cause the malocclusion. Diet deficiency or some folic acid, vitamin B12 will cause some defect. Thumb sucking habit will cause malocclusion. Thumb sucking usually occur upper incisor, also occur lower incisor, and causing what we call the open bite on one side or both sides or central. Tongue thrust, the tongue can cause crowding, especially anti-open bite, and proclamation of upper lower incisor. Lip biting, lip trap behind the upper incisor, cause proclamation of the upper incisor. Bruxism, grinding, nighttime, grinding nighttime. Tonsillitis, and can be due to abnormal adenoid. Adenoid is a lymph tissue, and when they enlarge and cause a blockage of the nose, then patient will tend to breathe through the mouth. So if the patient give opening the mouth, then it become a long face or high angle face. So this patient usually have a long face, and sometimes you're not careful, and they open bite, and then the narrow of the upper maxilla. Trauma can be due to trauma to TMJ or damage to TMJ. Then it causes asymmetry of the face. Local factor means the teeth. Can be extra teeth, supernumerary. So that is very common. They happen in between the central incisor. So it can be one or two. So sometimes always goes to take an X-ray. So verify there are no extra teeth inside. Sometimes you see one outside. Doesn't mean they're inside, there are no one. So a lot of time you have to take X-ray to verify whether there are one or two, or sometimes even 3 or 4. So if you take out one from the outside, then you miss out one inside, then it can cause negligence. People can sue you, or patient can sue you. So always take an X-ray when you see supernumerary, just to make sure there's nothing inside. Supplemental, it means a similar size or similar shape, but an extra. For this one, extra retroincisor. Okay, supernumerary. Okay, what's the effect? You can block something and deviate the other adjacent tooth. Okay, missing teeth just means something less so than normal. So the most common one, lateral incisor, upper 2, lower 5. Right, it causes gapping, tilting of the adjacent tooth. Peck shape means a smaller. Peck shape means lateral incisor. Sometimes it becomes a peck shape or smaller teeth. Then they cause aesthetic concern. So you have to build up this lateral incisor to a normal size for the patient to look better. Macrodontia, it means something bigger than usual. Okay, abnormality of tooth shape. And shape can be abnormal. It can be fusion, germinations. Then there's so many talents, dents, imaginators, then dilation. So fusion means two teeth will fuse into one. So you look at the number, usually these two incisors, then become one, they call it fusion. So you count the number first. So fusion and germination can look quite similar, but you count the number. So like this case, the lower left 1 and 2, there's no extra teeth. So this one considered fusion. So you have one more extra T next to it, then consider germination. So you look at the number. So it's the germination, it means an extra T. Central incisor, this one also central incisor, canine. So you see central incisor become 2, so lateral incisor become 2, call it germination. 1 become 2, become germination, 2 become 1, call it fusion. Okay, talons cup, it means it's just like a talent, like an eagle talent. So this one usually happen on the lateral incisor or central incisor sometimes. Then it can happen on the buccal surface of the molars. So whatever shape look like a talon, they call it talon cup. So this talon cup is just something extra. Sometimes it causes a disturbance to the occlusion. Then sometimes more prone to caries with the foot stuck. Dense imaginators means the two in the two. So there's a small T or small tooth inside the pulp of the other two. So this one usually is prone to infection because these two, they have a pulp inside, so they are more prone to exposure. So if they're exposed, then it causes what we call an infection. So you can see the infection that happen, then it affect the permanent adult teeth, which will cause the PA lesion at the end. Dense imaginators, it means two outside. Dense imaginators, it means two inside a tooth. This one, a two outside the tooth. Same thing, there's something extra. Just now, this one is something extra inside. Dense imaginator, it means something extra outside. It means an extra something, cups outside. Same thing, if this one break, then it will cause infection to the pulp. So sometimes it cause the PA lesion also. There's no picture here. Dilaceration, it means a crown root angulation change. Crown and the root angulation change is called dilaceration. So is this angle supposed to be straight? When I change the angle, you call it dilaceration. The most common one is the central incisor because when the baby teeth they injured about 4 to 5 years old, then they will push the central incisor upward. So that causes the development disturbance that causes the dilaceration. So of course, other teeth can happen without any reason. Whatever change in crown root angulation, we call it dilaceration. Labial frenum can be a tricky one. So because the labial frenum, they always happen a bit lower when you have a younger age. Then they'll move upward when you get a bit older. So when you see a low frenum attachment on a mixed dentition, you don't have to do any treatment too early. You wait until this permanent canine come down. If this frenum is still persistent, then maybe you will consider to reposition this frenum a bit higher and closing the gap with a fixed braces. Okay, premature loss, it means you're losing the tooth before the date is supposed to. So usually it will lead to the tilting of the adjacent tooth, or sometimes careful the over eruption on the top or bottom teeth. So if a prolonged retention, if some deciduous teeth refuse to go, then the permanent adult teeth cannot come out, or they come out in the crooked or atopic position. This is cause of crowding. So the baby teeth have to go at the right time. If they refuse to go, they cause problem. If they go too early, they lose too early, they cause problem also. So everything have to happen at the right time. Very important. So the eruption, refuse to come out. Okay. Usually due to blockage or something blocking the teeth from coming up. So it can be a soft tissue, mucosa, or it can be a hard tissue. Hard tissue means it can be odontum, or some extra teeth blocking, or it can be cyst. So whatever blocking the teeth from coming out, we have to remove it usually. Abnormal eruptive is the tooth erupted into the wrong position. Then usually the canine is the one. When you have a missing lateral incisor, then some say this lateral incisor will guide the canine from coming down. So if you're missing lateral incisor, sometimes the canine will lose the direction or eruption, and they come into crooked position. Ankylosis usually due to trauma, or sometimes without any reason, it can be ankylose. So if the fusion between this cementum or the periodontium into the bone, if this periodontium is gone, then the fusion between the cementum to the bone, then we call it ankylosis. So usually cementum separated by the periodontium to the bone. So bone, periodontium, cementum. If this periodontium is disappeared, then the fusion between this cementum and the bone, then it can be a problem. Then it causes ankylosis. And so whatever happens, then the tooth is stuck. The other teeth will keep erupting and become longer, but this tooth will become shorter because they are fused or stuck with the bone. Proximal caries is whatever caries or sometimes not well done filling, then can cause disturbance to the occlusion, then they cause the malocclusion. Okay. Second topic is done. Any questions? Are you still there?
Yes, we're here.
Okay. All right, good. Now we go to malocclusion class 1. Malocclusion class 1, let's see. Okay. So occlusion class 1, it means the incisor class 1, then skeletal class 1. I call it malocclusion. So class 1, when the molar incisor, the class 1, they still have some crowding on the 3, 4, 5 regions. Most commonly is the 3 on the top, and then the bottom, usually the 5 region, because it's the last 2 to come up. So even though your class 1 molar, class 1 incisor, you still have crowding. Then we call it malocclusion. So this one can be class 1, then patients still have crowding. So we call it malocclusion. So you have to know as definitions, class 1 malocclusion. Then how to diagnose a case, you need some clinical examination, study model, radiograph, and sometimes photograph. Photograph, you see bottom right, there's some photograph. Etiology, class 1 malocclusion, soft tissue, skeletal, dental, soft tissue. Due to habit, this one two-side discrepancy. I mean the jaw is too big, then sometimes the size of the teeth too small, or the size of the teeth is too big, the jaw is too small. So if the jaw is too small, then the size of the teeth is too big, then it causes crowding. If the jaw is too big, then the size of the teeth is too small, then it causes spacing. So either one will cause malocclusion. So it has to be balanced between the tooth size and the jaw size. Okay, intraoral features. Intraoral features can be spacing, rotations, crowding, cross-bite. But you see the incisor is still on class 1. They can have deep bite, open bite, proclination, upper lower incisor, what we call the bimax proclination. Crowding is very common. Class 1, mostly crowding, then you have to treat with the extraction. Usually it's a balance, 2 up, 2 down, left 2, right 2. So total 4 premolar extractions. It's very common for class 1 crowding. Okay, late lower incisor crowding, you have to know what's the reason. A lot of people say because of the third molar wisdom to come out, then they're pushing everything forward, they cause the incisor crowding. By right, this third molar maybe contribute to a fractions or very tiny little bit of this lower late incisor crowding, but the most important or the main reason of this lower incisor crowding is because of this mandible rotations or mandible still growing forward. Then the upper teeth, so the lower teeth is trapped behind the upper teeth, then plus the soft tissue pushing a little bit, then plus a little bit of mesial migration of posterior teeth, then cause a lower incisor crowding. So you don't tell the patient you remove the third molar, can you prevent this lower incisor crowding? That's wrong, because most of the lower incisor crowding, late lower incisor crowding, then happen because of the jaw. It's not because of the third molar. So you can ask many people, they can tell you they used to have a straight teeth when they're young, then when they become older, then this lower incisor become crowded. That's very, very common because of the late lower incisor crowding. So diagnosis, you have to do clinical examination, model analysis, discrepancy between 0 to 2 mil. Okay, this one is just a displacement between the mesial surface or distal surface, then you classify it to mild, moderate, and severe. Same for the crowding, you classify the crowding into mild, moderate, and severe. So this will determine extractions or non-extraction case. Then if you come to severe crowding, then usually extract the premolar, first premolar, because the first premolar is right at the corner. So you want to maximize the space, so they extract the first premolar. And when you don't need so much of space, moderate crowding, they extract the second premolar, because the second premolar is a bit further back, so you don't need that much of space for the alignment. You extract the second premolar. And when it comes to mild crowding, then you can expand the jaw a little bit, or you can do some interproximal stripping by slimming down the tooth about 0.5 interproximally. So you can cut the tooth a little bit by bit, every single interproximal space. By doing that, then you can get about 0.5 for each space you cut. Of course, you cannot cut the teeth too much, because if you reach a second layer, which is dentin, it will cause sensitivity. So that's a limitation how much you can cut. But 0.5 millimeter is quite safe. So of course, some mild crowding, you can use the removable appliance. You can use neck spring, labial bowl to close the gap, neck spring to push the incisor forward. So simple removable appliance sometimes can achieve the result the patient wants. But when you come to the more severe case, then usually the fixed braces will be more suitable. Okay. So how we gain space, this one is very important. I think this one, everyone who's doing braces, you have to know how to create space. Because you want to align or you want to straighten something, you need space to do that. So the first method is proximal stripping. Like I say, you slim down or you cut the teeth interproximally, then 0.5 millimeters. If you do 2 cutting, then you get 1 millimeters. Then you cut 3 or 4 spaces, then you get 2 millimeters. Then if you cut from 6 to 6, wow, then you can get 4 to 5 millimeter space. So that is quite a lot. So if you want to do more space, you cut more teeth. Simple. So if you need a lot of space, let's say you need more than 5 millimeter space, of course, straightforward, you take out teeth. So you see the braces, very simple. Enough space, we don't take out any teeth. Not enough space, we take out teeth. That's simple. Of course, you can expand the arch. You can whiten the arch. By whitening the arch upper, lower, and you gain some space also. Same thing, number 4, proximal stripping, repeating. Molar distalization, it means pushing everything backward, then you get the space for the front teeth to align. So uprighting teeth, so if the teeth is tilted, then they occupy more space. If you upright or straighten the teeth, they will create space. The rotations. You see the two, they are rotated, they will occupy more space compared if you straighten the teeth, they will gain space. Proclination of the incisor. So usually if you procline the upper lower incisor forward, you gain some space. So you just tell you removal and fixed appliances can fix this malocclusion. So simple malocclusion removal is a more complicated one, you deal with fix. Rotations, yeah, you can deal with fix, but rotation is not good to do it with removal. Removal is good to push the teeth forward and backward, but it's not good for rotation. Impacted tooth usually you need fixed braces to do it. You have to expose the canine, then you have to find the canine, and this stick something like a gold change or attachment on it, then use the braces to pull it down slowly. I see this as surgical exposure, then expose, find the canine, then I put a gold change, then attach a gold chain, use the braces to pull it out slowly. Of course, first thing, you have to create the space first. No space, no alignment. Simple. So space first, then alignment later. So spacing is very simple. You have more than enough space, so you don't take up any teeth. So you have more space, then you can straighten the teeth straight away. In fact, the extra space, you have to close it with braces. So again, simple spacing like upper median diastema, you can consider removable using a Hawley or labial bowl. Then you can close this median diastema. When it comes to big space, then it's better to deal with the fixed braces. Habit, thumb sucking. Thumb sucking is a very difficult habit to stop, but you have to tell the patient why you have to stop. You have to explain to the patient, parents, and the mom, so they understand what's wrong with the habit. Because this thumb sucking habit will create anterior open bite and pushing the upper incisor forward. If you suck your thumb too long, the anterior permanent dentition established, then this effect can be permanent. Means you're going to have permanently anterior open bite even when you stop the thumb sucking, which is too late. So the best time to stop the thumb sucking is before the upper and lower incisor, permanent incisor era, and the effect will be temporary. So why the kid like to suck the thumb? That's because the transition period from the breastfeeding then to what we call the self-feeding. So the patients or the kids, they always feel a bit more secure and they have something to suck. So you have to understand the psychology part about it. So if you stop it completely or suddenly, then the patient will feel a bit insecure. So sometimes you have to think of other reason or other method to stop this habit gradually. Median diastema very common. So it can be due to the frenum, or it can be due to the physiological space, too small, then the space is too much, or the arch is too weak. Then it can be due to the frenum occupy the space between the central incisor, or it can be due to something stuck between this central incisor. For this X-ray example, you can see there's a supernumerary, the wedge between the central incisor causing the spacing. So like I said before, it's always good to take an X-ray. If you're not sure, you take an X-ray. Make sure there's nothing in between the central incisor. So if not, when you start closing the gap, this root of the central incisor might hit on this supernumerary, then it causing the resorption of the root. Then again, patient will sue you. So make sure you take an X-ray just to double check whether there's something inside blocking the teeth from coming to each other. Okay, malocclusions. Okay, so the most difficult part for braces is the retention. So when you come to retention, there are so many choices. You can do removable or you can do fixed retainer. So fixed retainer comes with disadvantage. It will cause a full impaction. So if you want to clean it well, there's no point having this fixed retainer. Crossbite. Crossbite, if they have a functional shift, means they have an initial contact. For example, this central incisor will contact first, then the jaw was shifted to left, right, forward. We call it displacement or functional shift. That's considered urgent. You have to treat the patient early for this functional shift. So you will call it the crossbite before they're causing more harmful effect. Okay, treatment choices, there are so many for crossbite. So this one, I think we talked about it before. You can use a class 3 face mask. I can use this tongue blade, then reverse the bite. Or sometimes posteriorly, you can use this expansion device, be it quad helix, rapid maxillary expansion, or coffin spring. All these will cause expansion. Expand the upper jaw, the one side or both sides, to correct what we call the crossbite posteriorly. Deep bite is very common. So deep bite, you have to identify whether the skeletal deep bite or tendon deep bite. Then you treat it with a different method. Okay, so the most simple one is using what we call removable appliance. Then putting what we call the anterior bite plane. Anterior bite plane means you have the plastic or acrylic on the anterior segment. So whenever they bite together, then this incisor, lower incisor will contact with the anterior bite plane. You see the posterior, they have a space. Then when this posterior molar erupted or erupting, then they will settle this deep bite. Have you ever lecture for removable appliance? Have you?
I don't think so.
Okay. Maybe you understand this concept a bit better when it comes to removable appliance topic. Of course, you can use a fixed braces. Fixed braces using a reverse curve. This one, I think, is not. You don't know like this one. You can use what we call the mini screw for intrusion of the upper and lower incisor. That's how we set the deep bite. Open bite, again, another very difficult malocclusion to solve. And sometimes can be due to thumb sucking. Then you have to ask the patient to stop this habit. Then this teeth will slowly come together. Again, they divide into dental open bite and skeletal open bite. And both causes, you have to treat it with a different method. So when it comes to skeletal, sometimes you need surgery. But when it comes to dental, then mostly braces can settle. Okay. Malocclusion, bimax. Bimax, it means the lips stick out a bit too much, or the teeth stick out a bit too much. Then you take out some teeth in the middle, they push upper lower incisor backward. By changing the incisor angle, the lip will come back. So usually for aesthetic reason. Right? Okay, we finished class 1 malocclusion. Any questions? No? Then we go to class 2 malocclusion. Class 2 malocclusion, I think we just have a lecture before. Maybe we just go through it quickly. So class 2 malocclusions, then you divide it into class 2 division 1, class 2 division 2. The main difference for this class 2 division 1, class 2 division 2 is angle or the inclination of the upper incisor. So for this upper incisor, which is procline, then usually class 2 division 1. If retrocline, usually class 2 division 2. So class 2, it means the teeth stick out, increase overjet, or the molar is mesial-buccal cups is biting mesially to the mesial-buccal groove of the lower molars. Okay, classic example, molar, okay, incisor. Then we have these subdivisions. Okay, then etiology can be upper jaws too forward or the lower jaw is too backward. Either the upper jaw is too long or the lower jaw is too short. Or it can be combination of both. Then how we assess, usually we cover the top jaw or the bottom jaw. Then we know whether they are assessed or they are normal. So it can be due to the mandible rotate backward as well. When the mandible rotate backward, then you're going to have an increased overjet. Okay. Soft tissue can be lower lip trapped behind the upper incisor, and they're pushing the upper incisor forward, procline the upper incisor. So this class 2 division 1 usually have incompetent lips. The lip cannot close properly, but they still can bring it to competent if they consciously do it. You can stretch the muscle, they still can close the lip. But if you ask them to rest position, then usually this lip is not competent. Can be due to thumb sucking. Again, thumb sucking is pushing the upper incisor forward, lower incisor backward. Create what we call a class 2 division 1 with the anterior open bite. Okay, it can be due to the trauma to the TMJ, then causing the poor development of the mandible, then that's why the mandible is short. Okay, we assess the patients. Okay, anterior, posterior, vertical, then you try to do it 3D and 3 dimensions, from the front, from the side, and then, from anterior, posterior, vertical, and transverse. Soft tissue, you assess soft tissue, competence or incompetence. Okay. So you see, ideally the lower lip should rest on the upper incisor. That's how we call the competent lips, with stable occlusion. When the lower lip is trapped behind the upper incisor, it proclaims everything forward. So that's not right. So that's what the aim of the orthodontic treatment. Try to achieve the stable occlusion. That means they have the bite between the upper and lower incisor, with the lower lip resting on the upper incisor, about 1/3. That's what we call stable or equilibrium occlusion. Okay, facial appearance, like I say, it can be due to the upper maxilla is too long or the lower incisor is too short. Okay. All right. Occlusion. Treatment, you can do orthodontic camouflage. You can take out teeth, then push it back, or you can use functional. Then when it comes to too severe cases, then you deal with surgery. So these are classic example for upper extractions and lower extractions of premolars, and can reduce the overjet by wearing what we call a rubber band later. So these are same again extractions. Okay, class 2, severe. Okay, severe, moderate, you still can do braces. Then when it comes to severe cases, then you have to do surgery. Okay, class 2 division 2, it means the upper incisor retrocline. That's usually due to the lip. The lower lips cover the top front teeth, but not the lateral incisor. Because the lateral incisor is a bit shorter, that's why you can bypass the lips. So the lip only covers the upper incisor, the central incisor. That's why they're pushing up in central incisor backward, but they let go of the lateral incisor. So that's why lateral incisor it can still be normal inclination, but the upper central incisor will be retrocline. Soft tissue, okay, this one usually have a reduced lower face height. That's why the lip can cover the top lips, then become very strong muscle, they're pushing everything backward. Sometimes if you are very strong muscle, it can cause a bimaxillary lateral lesion. So you push not only the upper and the lower also. Classic example, upper incisor, central incisor backward, lateral incisor forward. Okay, this is treatment plan is the inter-incisor angle. You have to achieve the stable bite, which is about 125 to 135. This one called inter-incisor angle. So usually class 2, division 2, they have this increased incisor angle. Then once you reduce it to normal angle, it means they have a proper bite. This lower incisor will rest on the upper middle third of the palatal surface of the upper incisor. Then this bite should be stable. Okay, we talk about the root talking. Then talking means the root, changing the inclination of the root. Reduce the bite, you can use so many methods. Then removable, then occlusal plane. Extrusion of the posterior segment, or even surgery when it comes to severe cases. Okay, we finished class 2. Any questions? No? Okay, so we go to our final topic, which is class 3. Class 3. Okay, so class 3 is very simple. Class 3 means the lower teeth stick out more than average. Usually they are the reverse bite or cross bite anterior. They can see, even though they are walking on the street, you can see the lower jaw is sticking out so much. They usually class 3. Easy to identify because very strong features. but very difficult to treat. So you can see this one example, lower incisor stick out compared to the upper, the reverse bite. So how much the teeth will be in the reverse bite? Sometimes only 1 or 2 incisor is a mild castry. So if the jaw is getting longer and longer, the cross bite extend to the posterior segment, sometimes even until the second molar. That's considered severe castry. Okay. So usually genetic. Castry is genetic, mostly. So if you see the parents, either the mother or the father's side, you have a castry features. So sometimes castry is difficult to deal with because they're always in your gene. Means your children, your ancestor, everyone have this castry gene. Sometimes it skip 1 or 2 generations, but it keep passing down to the next generation. Sometimes people will blame it to this enlarged ethinoid. I say this ethinoid is the lymph node or the lymphoid tissue. Then sometimes they get infected, they get enlarged, then they block the airway. Then patients tend to breathe through their mouth rather than the nose. Then by doing that, then the face will become longer. Then they have a high angle or backward rotation of the mandible. Etiology, same with class 2. It can be due to the short maxilla or the long mandible or a bit of both combination. So concave profile is very common for castry. Long face. Intraoral, crossbite, anterior, most common, sometimes extend to posterior, buccal crossbite, crowding on the upper because the upper jaw is more narrow compared to the lower jaw. Because the lower jaw is too big, upper jaw is too small. Because the upper jaw usually have crowding, lower a bit straighter. Intraorally, obviously the molar is class 3. The mesial buccal cups occlude distally to the mesial buccal groove. Pseudocastry is an interesting one because it means the patient can bite on the incisor edge to edge, but because of posterior they don't have any bite, so the patient will slide or glide forward so they get the maximum contact on the posterior segment. So we call it displacement or functional shift. So patient estimate the forward part of closure. So this one called habitual castry or pseudocastry. Mean they are not that severe castry. They can still manage to bite edge to edge incisor, then the mandible glide or slide forward, then become more castry. This kind of case is a bit easier to treat because they are not severe castry. Okay. So you have to determine whether the skeletal, dental, or pseudocastry. Then it will be easier for you to plan the case accordingly. Again, study model, radiograph, sometimes photograph will be necessary. So castry factor to be considered patient skeletal, severity of the skeletal. So I would say this one is the most important, severity of the skeletal, whether they are long lower jaw mandible or the short upper jaw maxilla. So if they are too short or too long, so sometimes surgery might be necessary, alternative surgery. Sometimes it can be single jaw, we cut upper jaw or lower jaw, or sometimes double jaw, then rearrange the jaw to a better proportion. So if this patient can achieve what we call the edge-to-edge incisor contact, then it means this patient have a good prognosis for camouflage on knee braces. If you cannot achieve what we call the edge-to-edge, cannot bite the incisor together, then usually this one we consider more complicated or more severe castry. And usually sometimes patient needs surgery. Dental alveolar compensation. So sometimes when I have a class 3 patient, the upper incisor always porcine and lower incisor always retrocline because the nature is trying the best to achieve the positive overjet and overbite. So that's why the upper incisor porcine, lower incisor retrocline. If this already happened to the maximum, and this patient is best to deal with surgery. If there's not much of dental compensation happen, then maybe you can do braces on it. Use a compensation method or camouflage method to deal with this castry. When to treat? Class 3, usually we tend to wait a bit longer compared to other malocclusion type. Because class 3, the mandible will keep growing. So you don't want to do it too early because the result not stable. So you have to wait until the patient more or less stop growing, and you go in, then the result will be stable. Of course, you can intercept. Intercept means you use what we call a face mask, or sometimes you will use a functional, reverse functional, twin block, then try to reduce the severity of the skeletal pattern to a certain extent. So that chin cup combinations, screw, this one's a face mask, reverse pull face mask. And chin cup. Okay, screw, biplane, rapid maxillary expansion, or sometimes you can do it with extraction, top and bottom, premolar, then using the rubber band to correct it with the fixed braces. This method, we call it camouflage. Means they are still class 3, skeletal at the end, but by tilting the angle of the incisor, changing the angle of the incisor, we reverse the bite. So this one called camouflage. It's not the true correction of the skeletal, but we're changing the angle of the incisor. So you want to do orthodontic camouflage, a lot of time it involves extractions. Okay. Of course, when it comes to severe case, you do orthodontic surgery. You cut the upper jaw, lower jaw, or sometimes upper and lower jaw. Then this usually have to do when the patient stops growing, which means they're adult patient, because you want to do surgery only once. You don't have to do multiple times when they're still growing, which is not stable. That's how you wait until the patient is more than 18 years old, then you do the surgery once and settle it for all. This one, you see bottom pictures, they're doing upper and lower jaw surgery. Mandible setback, then maxillar advancement. Okay, PSSO with the mandible only. The fourth one means upper maxilla, they break the upper maxilla, bring it forward. PSSO, it means to bring the mandible backward. So it can be both. You can do upper maxilla advancement, lower mandible setback. Combination of both give you the best result. Okay, I think basically I covered all the topic for your tutorial. Do you have any question to ask me? Any questions?
I don't think we have questions.
Everything clear?
Yes.
Okay. If no questions, then I think we end this tutorial here. But any questions, you can text me or ask me during the next lecture. Yeah. When are you coming back? Campus?
We don't have our schedule yet, but supposedly the 3rd or the 4th.
3rd or 4th next month?
Yeah.
Oh, okay. Very soon then. I'll see you probably the next 2 weeks. Yeah. Okay. See you. Goodbye and Merry Christmas.
Thank you, Doctor. Happy holidays.
Happy New Year.
Thank you, doctor.